So more symptoms of upper motor neuron lesions, and we'll talk about some treatment for different pathologies. Same, we're still talking about upper motor neuron and motor tract lesions. We're going to talk about clonus and clasp knife and lead pipe rigidity, which are pretty interesting. And then we'll talk about a couple different pathologies. So rigidity, it's velocity independent hypertonia. Remember, spasticity is velocity dependent. Some basal ganglia disorders cause rigidity, particularly axial rigidity, rigidity of the trunk. Resistance to passive movement remains constant regardless of the speed of force application. There are two types. This is common with brain injuries, decerebrate or decorticate rigidity. So with decerebrate, you get extension of all the limbs and the spine and the head. So everything's in extension. With decorticate rigidity, everything's in extension except the upper limbs are flexed. So those are just two different areas of the brain um, and the effects of the rigidity. You can have rigidity in a single limb or one side of the body. It's not necessarily all over the whole body. Abnormal cutaneous reflexes can happen with some upper and lower motor neuron issues. So the plantar response, it's also called the Babinski's reflex, Babinski's sign. You stroke the lateral sole of the foot from the heel to the ball of the foot and then across the ball of the foot. And you stop before you get to the ball of the big toe. The normal reflex is either nothing or your toes curl, your toes flex. If you get extension of the great toe and fanning of the other toes, that's the abnormal response. That's Babinski's sign. Little babies, before their reflexes are integrated, have positive Babinski sign. Once their motor reflexes are integrated, though, then they have normal plantar response. So in spinal cord injury, muscle spasms can occur in response to cutaneous stimuli. Spasms begin after recovery from the spinal shock. So during the spinal shock period, which is maybe the first few weeks after the injury, you have hypotonia and flaccidity. The afterwards you get these abnormal reflexes, and the most common ones are muscle stretch hyperreflexia, clonus, and clasp knife response, and we'll talk about what those are. So clonus is an involuntary repeating and rhythmic muscle contraction in a single muscle group in response to a sustained muscle stretch. So in people with chronic spinal cord injury or other upper motor neuron lesions, I've seen this a lot in MS. Sustained clonus of the soleus muscle might be triggered by placement of the foot on a wheelchair footrest, or you're getting onto the new step and you do that. Unsustained clonus fades after a few beats, even if you maintain the muscle stretch. Sustained clonus is more than 5 beats, and it's always pathologic, and it's produced when a lack of upper motor neuron control allows the activation of oscillating neural networks in the spinal cord. So it's like foot jitters, if you want to think of it that way. Um, and so it is inconvenient when you're trying to stand up and your foot goes into dorsiflexion and you get that clonus. Usually we will, when we chart that as a symptom, we'll say how many beats, or more than 5 beat clonus or less than 5 beat clonus, something like that. So I have seen it a lot in people with MS and with spinal cord injuries. Clasp knife response occurs when a paretic muscle is slowly and passively stretched and resistance drops at a specific point in the range of motion. And they call it clasp knife because the change in resistance is like opening the blade on your Swiss Army knife. There's initial strong resistance to opening the knife blade, but then it gets easier. So there are type 2 afferents elicit the clasp knife response. So it's like resistance, and then nope, no more resistance. And so that is common in people with spinal cord injuries. So common signs of upper motor neuron lesions include paresis, paralysis, abnormal timing of muscle activity, Babinski's sign, and myoplastic changes. With chronic spinal cord injury, hyperreflexia from the phasic muscle stretch reflex, clonus, abnormal withdrawal reflexes, and clasp knife phenomenon. And that those can happen with other upper motor neuron lesions as well, but they're common in chronic spinal cord injury. In stroke, spastic CP, and spinal cord injuries, emotional agitation and pain can lead to excess muscle force. So the actions of the emotions on the motor cortical areas um, can elicit signals from non-specific upper motor neurons to lower motor neurons. And so when someone's agitated or upset, sometimes it's when someone's frustrated because they're trying to do something that they can't do. It leads to excessive hypertonia or excessive muscle force. So it's kind of frustrating. You're trying to do something and the muscle's not cooperating. After stroke, um, you can get improved movement has been demonstrated with hand and finger movements against resistance, robotic therapy for the upper limb. So that's where you have a device that is helping to move your upper limb. It's kind of cool. Constraint induced movement. So you basically constrain the more able side and you force the more impaired side to do the task. Cycling, and it can be just active cycling or functional electrical stim cycling. Task-oriented gait training, so like walking from one place to another. Task-oriented gait training using a treadmill, and that's the picture on there. It's the partial weight-bearing assisted treadmill, and a lot of times you're down on the floor directing the more affected leg and proper stepping. Virtual reality has also been used pretty effectively as an intervention post-stroke. So there was a type of therapy called NDT, can't say it, developmental treatment, which is basically where you avoided effortful movements with the paretic muscles and you use techniques to decrease muscle tone. And the latest studies are showing that that is not as effective as task-oriented training. Sometimes Botox injections are used as an adjunct to therapy, but it's not consistent whether it's beneficial or not. So some people get some reduction of spasticity with Botox, or they get some better movement, but a lot of times you reduce that spasticity and now they are unstable. So it's a toss-up as to whether or not that's beneficial. With spinal cord injury, activity-based therapy is something that activates the neuromuscular system below the level of the lesion. So the picture is a robotic assist treadmill, which is pretty cool. For people with a complete spinal cord injury with intact lumbar cord below the lesion, appropriate stimulation can activate stepping pattern generators and elicit a walking EMG pattern at the hips and the knees. So that's kind of what the robotic assist does, which is pretty cool. Somatosensory input to the spinal cord during treadmill training with body weight support elicits neuromuscular activation that doesn't occur during overground walking. So there's some advantages of treadmill assisted treadmill walking, body weight support treadmill walking over just walking on the ground. Um, with to appropriately stimulate the muscles after a complete spinal cord injury, body weight support, weight bearing on the treadmill, implanted lumbosacral spinal cord stimulators, or manual assistance. And if you're doing manual assistance, you need a lot of helpers. So, people have to move. One person has to move one leg, one person has to move the other, one person has to control the machine. So, it's not something that's simple to do. But if you work in a clinic where it's set up, it's pretty cool. one of the former graduates of this program worked at a rehab hospital where they had a robotic um, stem suit that they used for people with spinal cord injuries, and that's pretty awesome. Functional electrical stim in spinal cord injury is really useful. I've done this a lot because I worked in a facility where we had functional electrical stim. So functional electrical stim is either implanted or skin surface electrodes, most commonly skin surface electrodes, which is what we used. It promotes recovery of neuromuscular function. Sometimes it, not always with spinal cord injury, not especially with complete spinal cord injuries, but with other upper motor or lower motor neuron issues, FES can lead them to more function, and you can start out using functional electrical stim, and then you withdraw the stim, and they've regained motion, which is pretty cool. Sometimes functional electrical stim is used for a neuroprosthesis, like in stroke, where you have a functional electrical stim device that stimulates the tibialis anterior to get increased dorsiflexion. The use of drugs to control spasticity resulting from spinal cord injury has been common practice, although it's variable results and there's some changing in the understanding of spasticity. So it's not across the board common like it used to be. So the medications that interfere with hyperreflexia or with brainstem upper motor neuron overactivity include things like baclofen, tizanidine, and some of the other ones. They're often used for people after stroke or with MS. The problem with oral baclofen or oral tizanidine is sometimes if you get enough dosage for it to be effective in reducing spasticity, it makes the person sleepy. So one of the things that they'll do is they'll use a baclofen pump, and so the pump actually injects the baclofen into the thecal sac. They call it interthecal baclofen, and so you can get the effects you want with much lower dosage and reduce the side effects. So there was a systematic review of 101 randomized trials, and none of them rated really high. So medication for spasticity, it's works for some people, it doesn't work for some people. Um, but it's one of those things that the neurologist will try to help someone reduce their spasticity. In people with neurological conditions, stretching does not prevent or reverse contracture. So, post-stroke, 1 year of intense gastroc and soleus, so triceps serrae stretching, combined with active antagonist muscle contractions, in addition to conventional therapy, didn't do anything to improve walking speed in the study quoted in the book. People with normal neuromuscular systems, regular 30-minute hamstring stretching for 6 weeks doesn't improve muscle extensibility, but it increases tolerance to discomfort during stretch. That was always my thing about hot yoga. I felt like it doesn't really make you more flexible. It just decreases your discomfort during the stretch, and so it increases your tolerance. So the research is backing me up on that. Well, it doesn't say hot yoga, but that's my theory about hot yoga. So, ALS, or amyotrophic lateral sclerosis, is a disease that affects lower and upper motor neurons, and you get bilateral destruction. Lots of horrible signs that we've talked about: paresis, hyperreflexia, Babinski's hyporeflexia. So you have both hyper and hypo. Muscle atrophy, myoplastic changes, hypotonia is on there twice. No, hyporeflexia, hypotonia, atrophy fasciculations, and fibrillations. So lots of issues, lots of issues with ALS. And the terrible thing about ALS is it's idiopathic and there's no cure for it. So that's all I have to say about that.